Hello. So this is a case report of atypical HUS, and to start off, both atypical and typical HUS are defined by three criteria. So that's microangiopathic hemolytic anemia, thrombocytopenia, and AKI. So typical HUS is a post-diarrheal syndrome, most commonly after Shiga producing E. coli or Shigella. And atypical HUS is a rare disorder of the complement pathway. It's most commonly due to genetic mutation, but can also be secondary to antibodies. So both of them still meet the three criteria that I just mentioned, but the difference in presentation is that typical is usually post-diarrheal. Atypical is usually associated with some sort of trigger like pregnancy in this case or infection. And they have different treatments also. So it's typically supportive for typical HUS and monoclonal antibody eculizumab for atypical. And the reason I want to talk about this case is that the presentation of atypical HUS can have overlapping features with some other TMAs, including TTP and HELP syndrome. And so it's not a straightforward diagnosis, and a lot of the times distinguishing labs can take a few days to return, and these are all critical conditions that need early differentiation. So in this case, it was a 17-year-old G1P1 woman, and she was presenting on postpartum day 4. She had headache, dizziness, dyspnea, polyuria, and lower extremity edema. So she was diagnosed with postpartum hypertension, AKI, and microangiopathic hemolytic anemia, although schistocytes were minimal at first, along with thrombocytopenia. So she didn't have any history of diarrhea or bloody stool. The next day, she reported ongoing symptoms despite treatment with transfusion, magnesium, steroids, and eculizumab. And so that was sort of empiric treatment for potential HELP or atypical HUS syndrome. So her platelets continued to decline. They reached a low of 20. Creatinine peaked at 6.2 and BUN at 103. So they started dialysis. Given her lack of response, there was an increased concern for TTP. So they stopped eculizumab and started plasma exchange and prednisone. However, ADAM-TS13 returned and it had a normal activity level, so eculizumab was restarted and TTP was sort of left off the diagnosis. So by discharge, a lot of her symptoms had improved, but she still had an ongoing AKI. Her genetic panel came back weeks later. It confirmed she was heterozygous for a complement factor H gene, and that's consistent with atypical HUS. At 6-month follow-up, her kidney function had normalized and she continued on eculizumab indefinitely. So a lot of characteristics of this case can be associated with the different causes of postpartum TMA, so mainly these three: HELP, TTP, and HUS. So I wanted to make this Venn diagram to show that there's a lot of overlap in symptoms, which make the diagnosis pretty difficult sometimes. And the distinguishing labs can take time to return, and empiric treatment is urgent. And so the diagnosis of HUS is often made clinically via the characteristic triad that I mentioned of thrombocytopenia, microangiopathic hemolytic anemia, and AKI. And the likelihood of it being HUS also increases if the disease is persistent and the renal failure is severe and ADAM-TS13 is less than 10%. So each of these three conditions has different therapy, and so the correct diagnosis is important. There have been some new therapies that have come out, which makes the treatment regimen even more complex. So the final diagnosis and correct treatment were very evasive in this case. So first magnesium for HELP, and then eculizumab for HUS, flex and steroid for TTP, and then back to eculizumab for HUS. And fortunately, eculizumab was included in her early therapy and has been shown to be an effective therapy for pregnancy-associated atypical HUS. And that's all I have. So thank you for listening.